Wonderful. Well, thank you so much. And it's great to be with all of you. I'm actually closer to you today, I think, in San Diego than I normally would be when I am in my home state of Illinois, in Chicago. So it is great to be here with you in a topic that I think is incredibly important as we understand more and more who's at risk for cognitive decline, who's at risk for the brain changes that we see in these diseases that cause cognitive decline, and what do we do about it? What do we know? And how do we change that trajectory going forward? So I'm going to spend a little bit of time talking about what we know, what we don't know, and then a little bit about where some of the science is going as well. And I know I have a tight timeline because there's also a great discussion that is planned for the second half of today. So here's my disclosures. I am a full-time employee of the Alzheimer's Association. I have received funding from the National Institutes of Health and the Centers for Disease Control and Prevention, and my spouse is a employee in an unrelated field at Abbott Labs. A little bit about the learning objectives of what we will discuss today. We're going to talk about the current landscape of what we know in this space as we think about risk, prevalence, and incidence in different populations, and how this ties into those who may be at greatest risk for cognitive decline. Some of the examples of modifiable risk factors, what that means as we think about it, and some of the strategies that are being pursued. I will tell you right at the front end, I wish that we had that specific recipe, that specific information about what might definitively reduce a person's risk for cognitive decline and dementia. What we have is we have hints in the science, we have information that has helped design the next generation of trials, and hopefully we'll continue to get more and more refined in the way that we deliver these interventions, and ultimately we'll have those types of strategies, we'll have those types of very specific guidelines and recommendations for all individuals and all populations. A little bit about the Alzheimer's Association, although I know some of you know us quite well and some of you might not. We have a vision of a world without Alzheimer's disease and all other dementia. So while we are called the Alzheimer's Association, we actually encompass all of the diseases that cause cognitive decline and dementia. In this space. We have a number of strategies that we work to achieve our mission and vision, and that includes our very active public policy and advocacy arm, looking at increasing resources both in research and in the community at the federal level, at the state level, and locally. We also have our chapters and our field team who are very active in providing support services and resources, and I think there'll be some resources that will be shared as well that are local to the Idaho community. That's also got support groups and other information and other ways to connect in. And then we have our research team and the work that we do on the research side, really advancing the research forward across the entire spectrum of the research and the science, whether it be from understanding cells in a dish, best care interventions, or best care support types of interventions, all the way through clinical trials, diagnostic development, and studies that are moving us closer to prevention across the board. The Alzheimer's Association is the world's largest funder of Alzheimer's and dementia science today, with a little over $430 million committed, and again, spanning that entire spectrum. And some of what I'm going to talk to you about today comes from that initial funding or that seed funding. And then we've had the ability with the increase in the federal dollars to enable some of those larger scale studies to move forward to help our understanding of what might be risk or what might be contributing to a person's risk throughout life. So each year, the Alzheimer's Association puts out the facts and figures, which is really underscoring the urgency of what we're looking at when we talk about Alzheimer's and the other diseases that cause cognitive impairment and dementia. Today, there are nearly 7 million Americans living with Alzheimer's, and many more when you add in the other causes of dementia. And of course, the numbers of individuals that are providing care and support. So you certainly have the human toll, the numbers of individuals, the impact in our communities, as well as the economic toll that this has both on the individual, the family, and the community as well. So when we look at prevalence and incidence, we know there's this over 7 million Americans that are living with this disease. We know that nearly two-thirds of them are women, particularly in the United States. We do see this in some other countries. Canada and several countries in Europe have reported similar trends. We also know that older Black and Hispanic Americans are disproportionately more likely to have a dementia. than older whites, but exactly why is not quite understood. And then there's been recent work that's looked really in the native populations and within our tribal community to suggest that there is also a significant impact. For instance, this recent study, the Strong Heart study, noted that prevalence of cognitive impairment is approximately 54% in American Indians aged 70 to 95, looking at both mild cognitive impairment and dementia. So as we think about the continuum of the memory changes or the changes in cognitive impairment spanning um, that entire progression or that entire continuum. And this leads into some of where we're going to go in this talk, and this may suggest that there are opportunities to suggest things that we know are risk factors, so like hypertension, like diabetes. But across all of this, as we think about what might be those interventions, we need to ensure that we are also building out culturally sensitive screening opportunities and interventions that will not just be developed, but then will be uptook by our communities going forward. So when we look and drill down in terms of the prevalence and where people are living with cognitive impairment, Alzheimer's or other dementia, this study came out of the team from Rush University in Chicago, and it really is the first ever county level estimates looking at prevalence, and this is specific in individuals age 65 and older. And they found that the highest prevalence in Alzheimer's were in the east and southeastern regions of the country, and you can see that represented here. But you also see that there are a number of other places in the country where we do see large numbers of individuals that are affected by these diseases. They also found that when they looked at the demographics based on the census, that the characteristics in the community where they see the highest prevalence are also tied to a higher percentage of Black and Hispanic residents. That's tied into what we had just shared and really supporting the prior data that had been shared. So when we look at what might cause an individual's risk of cognitive decline, dementia, or any of these diseases that cause cognitive decline and dementia, it's really this constellation. And this is a cartoon representation of that constellation of things that maybe impact a person's brain or overall brain health as they age. So there's certainly things that are not necessarily changeable, such as our age or our genetics. But there are other things that may be modifiable or that may be able to be adjusted. So our level of physical activity, for instance, the quality of our sleep, the amount of cognitive engagement that and that maybe the type of cognitive engagement, although we don't know enough about that just yet. But there are a number of these other types of factors that we know play a role, at least in a person's risk of cognitive decline, but exactly whether we can intervene and change that trajectory remains to be seen. There has been some work, though, to do this and to develop those strategies. So as we understand what this constellation of factors are, how do we then address it proactively? So I'm only going to talk about a handful of them just due to time to give you a snapshot of what some of these factors are. And putting it into the context of the recent Lancet Commission report that was published at the Alzheimer's Association's International Conference this past summer, which suggests that there are 14 modifiable risk factors, which, if they were completely eliminated, so fully addressed, they would have an impact on nearly half of all dementia worldwide. Now, this suggests that all individuals with less education in early life, that we would address all of the education considerations, depression, and address all of the links of depression that we have seen tied in with cognitive impairment. So there is some question as to how that is, but it's a model that puts out the impact of these lifelong, really throughout our entire life course considerations, and how that may be impacting our later life risk. This new report from 2024 updates the prior report in 2020 and the prior report to that in 2017 with a couple new factors, and specifically looking at hearing loss and air pollution, and I'll talk about those in a moment. But included in this are things like sleep. And so we understand there are a number of studies that have been done over the years, and some of them have been observational studies that have measured sleep or sleep disturbances in particular, and then show when they followed individuals for many years that there is an increased number of individuals that had or reported sleep disturbances or sleep apnea that also have dementia, cognitive impairment or dementia when they look 3 decades later. And so there's been a number of studies that have shown this. There's been a number of cohort studies that have also supported this. But the big question is one, what could potentially be the mechanism that's driving sleep linkage with brain health? And then two, what happens if you intervene and you're able to change the trajectory of the sleep disturbance or the sleep hygiene and correct it in a positive way? Are you able to impact the person's risk long term? So, when thinking about mechanism, some of what we understand increasingly around the biology is that when an individual sleeps, there are physiological changes in the brain that are supportive of clearance, brain clearance. Essentially, our brain takes out its trash. And this includes some of the things that we know accumulate in disease, like Alzheimer's, such as amyloid and tau. And when you have maybe a potential prolonged period of time where you have sleep disturbances, it's feasible that that may contribute to an increased accumulation of those brain changes that we see in Alzheimer's as well as other diseases. But I will tell you, there's a number of commonalities around this linkage of sleep as a risk factor, whether you're talking about Alzheimer's, Parkinson's disease, Lewy body diseases, progressive supranuclear palsy, and others. And in fact, the Alzheimer's Association has just partnered with Michael J. Fox Foundation for Parkinson's Research and Cure PSP on a funding program specific to understanding this biology. Now, there have been several studies that have shown, and they're relatively small in the number of individuals, that when they have intervened on the sleep disturbance, whether it may be with sleep apnea diagnosis with a CPAP, that they are able to lower an individual's risk. And so this suggests that addressing sleep concerns, improving a person's sleep hygiene, is a potential strategy for prevention, or at least modifying that trajectory or the impact that sleep may have on a person's risk. There's also a very strong link to vascular health. And of course, our sleep ties into our vascular health as well. And a lot of confounding factors when we look at vascular health, whether it be midlife hypertension, even early life hypertension, early or midlife obesity, diabetes, smoking. And in some cases, then smoking cessation, the level of physical activity, and again, bringing in sleep quality. And a number of potential mechanisms that tie in, looking at arterial stiffness, endothelial dysfunction. So, do you just not have the same strength in terms of the ability to push blood through in the same flow with the same overall efficiency? What is there oxidative damage? So, you're not necessarily then carrying the same level of oxygen, leads to downstream metabolic dysfunction, inflammation, and other activities or other changes in the brain that may make the brain more sensitive. So, all of these are links to the vascular health. And so we often hear that adage, what's good for your heart is good for your brain. And it really ties out in that biology when we've taken a look at that. One of the recent studies that was published came from looking at the SPRINT Mind trial. So SPRINT was a cardiovascular study that looked at aggressive treatment of the systolic blood pressure below what was standard of care at the time. The outcome tied to cardiovascular health and a decrease of deaths due to cardiovascular health was so positive in 2 years in the study that they actually had to stop the study, report out the results. Now, the SPRINT Mind, which was an ancillary study or an add-on study to this, was measuring the cognition of those individuals receiving the aggressive treatment versus those that did not. And what they showed is even after 5 years, with a 2-year intervention, that the individuals that had the aggressive treatment actually had about a 20%, it was an 18% reduced risk of mild cognitive impairment compared to other individuals without that intervention. Now, they continued to follow those individuals for about 5 more years with funding from the Alzheimer's Association as well as with the National Institutes of Health. And they demonstrated that reduced progression to mild cognitive impairment or mild cognitive impairment and dementia was consistent, whether it was 5 years follow-up or 10 years follow-up. Now, I will note, we didn't see a significant benefit on dementia, and there's a number of potential reasons for that, but it underscores this what's good for your heart is good for your brain long term. Now, thinking about some of the other factors, and as I'm sure all of you are hearing this or seeing this, you recognize that there's such an important intersection across all of these factors. There's been a number of studies that have looked at obesity as a risk factor for cognitive decline, whether it be midlife obesity or late life obesity. In midlife, it does seem to have a relationship to increased rates of cognitive decline and dementia. in later life, whereas late life obesity seems to have some sort of paradox or inverse relationship. And so when you have weight loss in later life, you may be more frail, and it seems to have a different impact. So it's really important as we think about that, like again, the lifelong contribution to risk when somebody might be at risk or having the impact of these different factors and what that might be on their brain or their long-term impact. And this could be driven by a number of things, again, tying into the heart health or the cardiovascular health and vascular disease. We know there's a strong linkage of obesity to cardiovascular and metabolic disease. There's been a number of studies that have shown individuals with metabolic diseases, whether it be diabetes, insulin resistance, or other, are also at an increased risk. Long term for cognitive decline. And there have been a number of strategies in looking at that as actually a potential drug target going forward. Now, thinking about this idea, obesity prevention, and if we can impact that, maybe a mean long term to reduce as a risk reduction strategy for individuals long term, not only with brain health, not only with cognitive impairment, but could also tie into some of the cardiovascular comorbidities that we see in individuals across the board. Now, one thing I will tell you is that when we look at the science, there's been a number of studies that have suggested that the new class of drugs, the GLP-1 agonists, may be tied to improved cognitive or decrease in cognitive decline. So when they pulled all of the participants in the trials testing the different GLP-1 agonists, those receiving drugs versus those with placebo, they found that those that received the drug compared to those with placebo over, I think it was a 7-year follow-up, had a decrease in cognitive decline and dementia compared to those who had received the medication. Today, there are 2 ongoing global trials that are testing GLP-1 agonists within a population of individuals with early Alzheimer's disease. So kind of tying those pieces together as we think about not only the lifestyle or behavioral strategies that may come along with these approaches, but there are also potential drug strategies going forward. There's been a lot of work and a lot of interest recently in thinking about hearing. And so this is maybe a slightly different approach or a different risk strategy, and this ties into some of what we've seen being added into the recent Lancet Commission report. There was a number of studies that have shown this linkage between hearing loss and dementia risk, and that could potentially be addressed with existing tools. If you have a hearing aid, what does that do for your cognition? There was the largest study to date called the Achieve trial, which was led out of a team in Johns Hopkins. And this was a 3-year intervention in individuals with hearing aids to determine if they were able to reduce the long-term cognitive changes in individuals that were thought to be at an increased risk. Now, when they looked at the total study, they saw no benefit or no significant benefit on the intervention over cognitive decline. However, they had a number of individuals that came through a particular route that had an increased risk of cognitive decline with that had cardiovascular risk as well. And in those individuals, that they found that the intervention cut the decline in half. So suggests that when we think about reducing risk or we think about impacting risk, it's that single target strategy may not be the most effective, but it's actually really how do we target or simultaneously target more than one risk factor for maximum effect or maximum benefit for an individual. And so really ties in that as we think about our brain and our overall brain health, all of these factors, whether you're talking about sleep, you're talking about overall heart health, metabolic health, hearing health, those all tie together about potentially giving our brain some resilience to other changes that might be linked to cognitive decline and dementia. And this idea of multi-component interventions is one that the field has been wrapping its arms around for the last several years as we think about heart health, that use it or lose it, the engaging of your brain, physical activity, nutritional guidance, and then some of these other things that may come into play. So for instance, you could think about multi-component intervention with hearing tied in to some of these other strategies. Now, there is some evidence to support this. There was in 2014 at the Alzheimer's Association's International Conference, the FINGER study, which is the Finnish geriatric study, reported out. This was in a group of individuals, over 1,200, that were cognitively healthy at the time of enrollment, but were at an increased risk for cognitive decline. It was a 2-year intervention with a lifestyle intervention versus usual care. And what they found is at the end of 2 years, they saw a benefit. The higher group is the benefit here on the graph a benefit in cognition and preserving the memory, thinking, and reasoning of this in this at-risk population compared to those individuals that had no intervention. But in Finland, it's a relatively homogeneous population, but also has incredible access to healthcare. And so the question was, would this translate globally? And would we see this translating globally? So the Alzheimer's Association, with researchers at Wake Forest University, launched a study that has 5 sites across the country to allow us to say, when we look in a larger population of over 2,100 participants receiving 2 interventions, self-guided or structured, over 2 years, are we able to see a similar impact in trying to have a greater representation, or at least aligned with what we see in the US Census? But of course, recognizing there is differences around the country and in regions where people may live. These are older adults aged 60 to 79 with no clear cognitive impairment at enrollment, but again, are at an increased risk for cognitive decline. Testing the 2 different interventions, the self-guided or structured, that incorporates physical activity, nutrition, cognitive exercise, and medical monitoring with data collection across the board, but also adds in things like imaging, sleep, microbiome association, and neurovascular measurements to allow us to say, well, what's the impact of this intervention? And do we see that it may be more impactful on one type of group versus another as we move closer and closer to those personalized approaches for intervention? Now, this trial is ongoing right now, but it is expected to be reporting out in the very near future at the Alzheimer's Association's International Conference this summer in July. So stay tuned for what that looks like and then how we move and translate that into community going forward. Because across the board, we have these hints in the science that tells us, using your brain, engaging your brain, eating a balanced diet, nutrition, having the nutritional balance, managing your cardiovascular and metabolic conditions, ensuring that you have the sleep. And it's really seems the data tells us it's more about sleep quality versus sleep quantity, maintaining or being physically active. And how do we put as many of these into our daily lives as possible? And the message that it's never too late to get started on incorporating these into your daily life as you can. The evidence tells us that individuals, for instance, already experiencing cognitive decline who engage in physical activity have a better outcome overall in terms of quality of life. So covered a huge amount of information. I was given 30 minutes, and so I think I'm right at that period of time right now. Just huge thank you to all of you. I do want to direct you to more resources at alz.org, including resources that are in your community locally across Idaho. And then if you have any questions, you can always feel free to reach out to me as well. And so huge thank you to all of you, and happy to have any questions.
Heather, that was fantastic. Thank you. I also wanted to put a shout out or make a shout out to Mercedes Munoz. She is the director of community-based programs at the Alzheimer's Association for the Greater Idaho chapter for helping connect us with you. So Mercedes, thank you to you. So we'll take a pause for any questions or comments. You can use the chat or come unmuted to ask those of Heather. Thanks.
Heather, this is Audie Black, neuropsychologist here. Incredible presentation. Thank you for those updates. I'm curious, one of the things we often hear from our patients is feeling overwhelmed by the number of lifestyle modifications we recommend. If you were advising your family member who maybe was at higher risk of Alzheimer's, what's the number one greatest thing you would tell them to focus on if they said, I can only make one change?
Yeah, I mean, great question. And I think that is why it's overwhelming. And so, how do we give people a very specific recipe? I think a lot of the strongest data is going to be in cardiovascular and metabolic management, probably followed shortly thereafter. And that ties into many of these other things, right? So, if you're managing your metabolic and your cardiovascular health, you're bringing in diet, you're bringing in exercise, you're bringing in sleep as well into some of those things. But that can be done with medication as well as with these behavioral lifestyle interventions. Again, depending on the patient, depending on the conversation, depending on a number of other factors that should be discussed with their clinician.
Heather, we had a question from Jeremy. He is our pharmacist on our panel for the GLP-1 effects on dementia. Can you put the sources? Is that possible to put that in the chat?
Yeah, I mean, I think probably the paper that I referenced specifically was published in Translational Research and Clinical Interventions in maybe 2021, but I will pull it up before I log off and make sure that you have the reference. And essentially what they did is they did this pooled analysis across the trial participants and saw this benefit. There's a number of other kind of publications that have been out there that look at the biology and suggest that there could be an inflammation mechanism or other things like that. I think one of the things I would, and I'm sure Jeremy, you would agree, I would really caution is the trials are going on now. We do not know what the outcome of those studies are, but it is probably the top question that we get in most places. And so I anticipated that for some of our clinicians, that's likely a question that they get as we hear some of these data or some of the science. So I'll put that one particular study, but there's actually an entire literature in this space that has really emerged in the last 5 years, looking at these GLP-1 agonists and their potential impact on brain health.
Kara, thanks.
Yeah. Hi, Heather. Thanks for your talk today. That was great. Wondering about the Pointer trial a little bit more. Can you say where we are in the trial's intended duration? You said there'll be a report out this summer, so just wondering how long the trial is intended to continue and where we're at in that.
So it's a 2-year intervention, and the 2-year intervention primary outcomes will be reported out this summer. The last participant is in a month.
Oh, okay. So it's completed then. All right.
The original trial is completed. We will have a continued follow-on of participants that choose to remain in the study going forward.
Thank you.
Any other comments, questions before we wrap this part up?
I was just going to ask a great discussion, wondering about the Native American risks, if you can update anything in that population that you might know as to why we're seeing that, other than what you mentioned on.
Wish I had more information. Unfortunately, there's only been a very small number of studies, and most have been trying to assess the risk and the linkage with risk. The Strong Heart study is the one that has recently come out and has really been from what I understand about it, a collaboration with a number of tribal nation leaders and others within the research community across the board. There are a handful of other studies that are looking, and many of them come out of the University of Washington, that are looking at different aspects and different care and resource related aspects within the tribal populations. There hasn't been a lot more that has been done. Unfortunately, at this point in time, I think a lot of it ties into some of the considerations around cardiovascular and metabolic relationships, but that's a hypothesis and not something that we know at this time, because we haven't done the studies of interventions within the tribal population to determine if that is able to reduce or alter risk.
Great. And we had another question in the chat. Thank you, from Dr. Horskamp. So since there are more women with Alzheimer's dementia, can you speak to the role of HRT and its effect on risk of dementia? That I've read mixed results.
Yeah, I think that's what we've seen. We've seen mixed results in terms of the relationship, what people have seen. I think in general, it's one of those things that is always a personal decision to make with your clinician and your provider. There are a number of factors that go into risk. It could be around the person's age. It could be things tied to their genetics, some of their the other risk related to other factors for HRT. Probably the largest study that's out there has come out of the Women's Health Initiative, and there's been some question around the interpretation of that data and how it was at least presented. It is that they saw this change, they saw this difference, but it wasn't really quite clear whether it was risk related, and there were some other confounders. That is not a great answer to tell you, because we don't have a definitive answer. There haven't been these massive intervention studies that have looked at linkages of risk. There have been studies that have made the association between risk, and also many other studies that have shown that there's no association. And both of them have been done in large claims using claims data populations. So not a great answer, but I think it's always a matter of then making an adjustment or an adjudication based on a number of other factors. It doesn't seem to be any one thing that's causal, and it's really a tie-in of a number of different factors across the board.
Thank you. So many of your answers are leading to the need for more research. Can you discuss any research connection with dementia and marijuana use?
I haven't had this question in a really long time. There are some studies that have looked at marijuana use. Although the data around self-report of marijuana use is pretty flawed. I see a few people nodding their heads based on their own, I guess, discussions with patients. And so it's not great data in terms of that linkage. Or if in terms of if there is a linkage. Now, what I will tell you is that there are several studies that are going on that are looking at THC related compounds to address agitation in individuals, but these are in clinical trials at this point in time. So data in terms of whether it impacts risk, unclear. Data that in terms of the potential impact of certain ingredients within marijuana that may be able to be used in a pharmaceutical grade treatment for individuals. And there is some of that happening in agitation or in palliative care studies ongoing right now. And I should also note there is actually also some work that's happening in marijuana use for the care provider, for the caregiver in terms of stress reduction and some other work. And I know that is ongoing as well.
Great. Well, Heather, we really appreciate you joining us. Thank you so much. This is a bit of a premature plug, but I'm going to make it anyways, based on some of the heart health information that you were talking about. So we will in the fall have a heart failure echo that we'll be launching. So stay tuned. I think nicely correlated with the efforts of this particular series as well. So thank you. Thanks for getting that information on kind of that research for Jeremy's question. And we are just grateful for your time and happy travels. I know you're headed to the airport after this. So
Thank you, everybody. Have a great rest of your day. Thanks for having me. Take care.
Thanks.